So we'll go on to the next talk, which I'm presenting, which is on colorectal cancer screening. And this is just a picture of the new Ohio State University James Cancer Hospital, which we're in the process of putting the windows on as we speak. It'll be enclosed by December of this year. It's a 1 million square foot building, and we have a $1.1 billion mortgage, which I am charged with having to pay. So we're hoping it'll be full. So good news in colorectal cancer mortality, and that is that we're finally seeing the curves go in the right direction. And the time points on here are the fecal occult blood test trial, which I'll talk to you about briefly. The time in 1997 when colonoscopy became recommended, and later when it became a Medicare benefit. So I would hazard to say that probably everybody in this room has medical insurance. Most of us are over the age of 50, judging from hair color, and hopefully none of us over the age of 50 have deferred our colorectal cancer screening. So what I'm going to talk about are guidelines, a little bit about disparities. There are a number of tests, so it isn't just PSA in my world. There are a number of possibilities for how to have colorectal cancer screening. I'll give you some suggestions from our greatest thinkers on this and a few take-home points. So one of the issues with colorectal cancer is that we can detect polyps which lead to colorectal cancer using some of our modalities, but only detect cancer using others. And you can see here the tests that detect both polyps, the premalignant condition, and cancer are flexible sigmoidoscopy, colonoscopy, and CT colonography. Few people are doing double contrast barium enemas anymore these days. Guaiac testing, or fecal occult blood testing, or the immunotesting for occult blood have a high sensitivity for cancer, but a low detection rate for polyps, and I'll show you the data on that. And then I'll also talk to you about genomics in colorectal cancer screening, the so-called stool DNA test, which looks like a very interesting potential technology for the future. So there have been many papers and many guidelines that have come out in the colorectal world, just as there have been in the prostate cancer world. We've, to some degree, questioned the guidelines makers because they come up with disparate recommendations. And so there actually was a group to give us a guideline about guidelines, the American Cancer Society process for how to develop cancer screening guidelines. And the U.S. Preventive Services Task Force, which Dr. Godley also noted has ruled on prostate cancer screening, has given us some recommendations on screening for colorectal cancer, and I'm happy to tell you that they still do recommend that up to the age of 75 in individuals who are fit and likely to benefit from early detection. Between the ages of 50 and 75, if you're African American starting at the age of 45, there is no controversy about colorectal cancer screening. And here is the clinical summary of what they've recommended. And you can see that they've tried to be flexible and said not everybody has to have a colonoscopy. There are other methods for testing. The high sensitivity fecal occult blood testing, sigmoidoscopy, colonoscopy, and also now most people are considering CT colonography as a possibility. For older patients beyond the age of 75, they don't recommend screening, although in my practice, everyone has had colorectal cancer, and I still do screen because they're at higher risk for colorectal cancer, as long as they're fit and I have a life expectancy projection for them of at least 10 years. Now, there are a number of disparities in the incidence of colorectal cancer. Men are more commonly affected than females, even though men are less commonly screened. It is a disease of aging. The median age is 72, and so when we talk about treating colorectal cancer, we're mostly talking about treating the older patient with colorectal cancer, and that can be fraught with difficulties if they have comorbidities. African Americans not only more commonly get colon cancer, they more commonly die of it, and they more commonly get it at a younger age. We now know that lifestyle affects your risk of colorectal cancer. If you're heavy, if you enjoy a fat-laden diet rather than a prudent diet, if you have a genetic predisposition to colorectal cancer, if you're sedentary, and if you have inflammatory bowel disease, all of those things increase your incidence and allow you to be categorized as a special risk group with special recommendations. African Americans and men more commonly die of colorectal cancer than women. So what are some of the tests? Well, as you know, the Cochrane Group has done many meta-analyses in a very scientific way, and this is one of them published in the American Journal of Gastroenterology, looking at fecal occult blood testing. And the Minnesota trial was the very first trial that did this up here, then the Nottingham, Funen, and Gothenburg trials. Very large numbers of people enrolled in these. And the bottom line was that by screening people with fecal occult blood testing, you could reduce the risk of dying of colon cancer with a relative risk rate of 0.84. And this meant a lot of lives saved. So it was interesting to hear in prostate cancer that preventing one death by screening 1,000 people was considered not to be an ideal use of screening. In colon cancer, preventing one death in 1,000 patients was felt to be valuable. And so we have different viewpoints about that. Now, one of the issues is if you do fecal occult blood testing, if anything is positive, you need to do colonoscopy. And of course, diet and other causes of bleeding can cause false positive tests. The advantages of fecal occult blood testing is you can do it at home without a bowel prep, it doesn't cost much, and it's non-invasive. The difficulty with it is that it misses a lot of cancers and a lot of polyps. And I'll show you a very interesting study we did when I was at Mayo Clinic about how it missed detecting blood in people with known cancers. Therefore, it often is falsely reassuring. Here is some data saying that physicians should not rely on a single stool sample. So the old rectal cancer or the old rectal examination with a smear done at that time is not the way that you do screening. You need to do 3 consecutive stools and do them every other year in order for this to be effective. Here's a study I mentioned. These are 10 patients with known colorectal cancer. And you can see that everybody whose guaiac test was below the blue line would have been had a negative test at the time that they came in to have a single fecal occult blood test done. So we would have actually missed more cancers than we would have detected if that had been the method of doing it. Now the FIT test is an immune test. It specifically looks at hemoglobin, human hemoglobin in the stool, so it's a more specific test. And in comparison with guaiac, it always comes out as being better. So the bottom line is that it's a higher sensitivity, higher specificity test. And so nobody should be doing the old guaiac-based tests. And here's the specific comparison. So if you look at this for advanced adenoma, neither of these tests are particularly good. The point I made at the beginning that fecal occult blood testing, whether you do it by FIT or by guaiac, is not good at polyp detection. It's better at cancer detection, but here the sensitivities are still terrible, much worse for the guaiac than for the FIT test. And advanced neoplasia is advanced cancer or advanced polyps. So it has a superior sensitivity and comparable specificity to guaiac. It uses antibodies. It's not affected by diet or medications, and it may improve compliance. Now, the genomic era has actually come to colon cancer detection. Stool DNA testing is biologically rational because rather than looking for blood, which is an intermittent marker of colon cancer present intermittently in the stool, this one is biologically rational because the tumors or polyps are constantly shedding cells. It's non-invasive. It doesn't require a prep. You don't have to restrict diets or meds. You can do it in the privacy of your own home and mail the sample to a collection center, and it's widely accessible. It's not affected by the lesion site. It's highly sensitive for both cancer and for the precancers. And this is actually a picture of the mucosa overlying a tumor on this side, and you can see all these cells being shed into the mucosa, as opposed to normal colon where the rate of apoptosis is much lower. And so these cells harbor the same mutations as any cancer cell does, and you can actually use these cells, if you can find them in the stool, and there are ways of finding them, to help diagnose cancer. Now, effective detection when you're using screening tests is a function of sensitivity of the test, compliance of the patient, and access. What we really want is a tool or tools that accurately detects colon cancer and premalignant polyps, is non-invasive, simple, doesn't require a prep or restrictions, is cheap, and is widely distributable. So the sensitivity is the accuracy. The compliance, of course, is how hard the test is to get and how hard the test is to go through. And the accessibility is affordability and distributable nature of the test. And this is a study that Dave Ahlquist and his colleagues published in Gastroenterology just this year, where they looked at the stool DNA test using markers of methylated genes, KRAS and hemoglobin. They looked at 678 patients with colorectal cancer and advanced adenomas present in many of them. And here you can see detection rates using their training set for establishing which genes to use, their testing set, and the combined set, which shows that you could detect colorectal cancer 85% of the time and adenomas greater than a centimeter 63% of the time. What's really important is to be able to detect not just stage 4 cancers, but stage 1 cancers and premalignant disease. And the aggregate sensitivity for this was 87%, which is very good sensitivity. And here you can see the larger the adenoma, the more cells are shed, the more likely you are to detect it. And then it doesn't appear that where in the colon the lesion is matters. You essentially can detect cancer in the proximal and distal colon with equal ability. The markers that are used are noted here, and the researchers have been working to optimize the methodology, and it continues to get better with time, so that now specificity and sensitivity for cancer exceed 90%. And so there's an FDA validation underway. Now, one of the difficulties for colonoscopists is sessile polyps. So sessile polyps are flat polyps. The way the colonoscopist usually can detect cancer is by seeing an irregularity in the profile of the colon, and flat polyps tend to hide. So we need better tests for detecting sessile polyps, and this test looks like it doesn't discriminate between sessile polyps and garden variety polyps. Screening test frequency. Now, we know that Pap smears are good at detecting cervical cancer, but you need to do Pap smears annually in the at-risk population in order to optimally detect cervical cancer. The same thing is really true of this methodology in colon cancer, where being able to do it in serial years brings the sensitivity up from 50% with the first screen to 75% with the second screen and into the 90s with the third screen. So the advantages of this: no bowel prep, sampling done at home, single stool specimen, non-invasive. The limitations: it'll still miss some polyps, the smaller polyps, and some cancers. The cost of it is much higher, obviously, than fecal occult blood testing. It's a new technology, and so we haven't had it to look at for a long time, and you still have to do colonoscopy. Now, what about flexible sigmoidoscopy? Well, the advantages of flexible sigmoidoscopy is it can be done by a non-gastroenterologist. The disadvantage is that it's often compared to doing a screening mammogram of one breast because you only get a partial look at the colon. This is about how far up a sigmoidoscope goes, and 70% of colon cancers are in the distal small bowel in men, but women tend to have more right-sided lesions, and so it's not as good a screening test for women as it is for men. And so you miss a lot of them. And overall, more than 50% of colon polyps and screen-relevant neoplasia is not detected by this methodology. The other thing that happens is the incidence of colon cancer in the right side of the colon goes up with age. So the older you are, the less likely a sigmoidoscopy is to detect your disease. And here you can see, however, that for colorectal cancer, the hazard ratio still is favorable for the use of this as a screening tool. And here you can see for overall colon cancers and for distal colon cancers, screening is better. But obviously for proximal colon cancers, you don't get any benefit for flexible sigmoidoscopy. It's relatively quick, few complications. It's a minimal bowel prep, minimal discomfort, and it can be done in a family practitioner's office or by a nurse practitioner that's trained in it. It only views about 1/3 of the colon. You still have to do a bowel prep. It's not as facile at removing polyps as colonoscopy is, and so you still have to do colonoscopy in the end. What about combining fecal occult blood testing and sigmoidoscopy? Well, the bottom line is that if you do 2 tests, it's better than doing 1 test, and you can get a sensitivity for advanced neoplasia of about 75%. This is what a colonoscopy looks like. So this is the typical pedunculated polyp. This is what it looks like when the colonoscopists see it. This is the snare that's used to lasso this polyp and retrieve it. And so you can do both diagnosis and treatment at the same time with this methodology. It's the best test for polyp detection and cancer prevention. It is, however, costly both in terms of the time spent in the prep, the time spent out of work recovering from the anesthesia, and the cost of the procedure and pathology if you need it. It's not perfect because you still do miss polyps, particularly the flat polyps. It requires a gastroenterologist to do it. But finally, this year in the New England Journal of Medicine, this publication that we've all been hoping for and waiting for about polypectomy preventing colon cancer deaths came out. And here you can see that in individuals who were randomly assigned to colonoscopy versus not, that there was a reduction in mortality from colon cancer in long-term follow-up. So the advantage is entire colon. You can biopsy and remove polyps. You can diagnose cancer. You also can diagnose other diseases in the colon, like carcinoid tumors of the distal ileum. You have to do it if you find an abnormal test of any of the other tests that we do. And you only have to do it every 10 years if you have a normal evaluation. It still can miss some polyps, and you do have to do the full bowel prep. Here is some data about the miss rate at colonoscopy, and you can see that it depends on the operator. And in very good operators, you can detect up to 98%, but in less good operators, it's 87%. there was an interesting study in the New England Journal of Medicine that looked at the withdrawal time of the scope. So the more carefully you look, the more you see. That's not rocket science, but somebody got a New England publication out of that, which I think is, and it changed the practice. So it used to be that nobody ever asked their colonoscopist, what's your withdrawal time? But now that's a quality measure for colonoscopists. All right. There is a small risk of perforation. It's more common with diagnostic procedures. Obviously, you take a bite out of the colon wall, you're more likely to perforate it than if you just go looking. But it's still very uncommon. 116,000 procedures, 37 perforations. What about CT colonography, also known as virtual colonoscopy? Well, it provides three-dimensional images of the colon. You don't have any sedation. You still have to do a prep, and you have to have air insufflation, which is uncomfortable and makes you socially unacceptable for several hours after you have the procedure done. And it also requires really expert interpretation. You still then have to have a colonoscopy if you have a positive test. But here are some of the amazing images that software refinements have led us to over the years in terms of what you can see on a virtual colonoscopy. It's done with a conventional CT scan, but different software. And all of these are polyps that are readily detectable using this technology. The sensitivity for detection of adenomas of 1 centimeter or greater is very high in the best studies. It is very operator dependent. The other thing that's of interest with this is when you do a CT scan, you often find collateral findings that are of value to managing patients. And here you can see some ovarian cancers, renal cancers, and others. It does still require a full bowel prep. Now, I mentioned to you flat polyps. They're harder to see. They're present in about 5% of the screening population, and they remain a problem for us. This is a flat polyp that is less easy to see than that cauliflower type polyp that you saw before. So screening steps. If you do anything other than colonoscopy, if you have an abnormal finding, it's a two-step process. One last thing I'm going to mention is the pill cam. You see the little pill cam here. This is now not only for small bowel screening, but is being developed for colon screening. It is good at detecting small polyps as it tumbles through the GI tract. And here you can see polyps that were identified by the pill cam. So my take-home messages for you is you shouldn't screen people of average risk before the age of 50, although African Americans have a higher than average risk, so you should consider screening at the age of 45 for individuals of African American ancestry. You do screen after the age of 50. There are a number of different options that you can use, including FlexSig and FIT test and CT colonography and then the DNA tests. You shouldn't do a rectal exam with a single smear. If you have any abnormalities with fecal occult blood testing, you do have to go to colonoscopy. The FIT test is better than guaiac, so guaiac should no longer be used. And obviously colonoscopy is the definitive step. So if you were to use a Netflix style rating for these, this is what you should remember. The gold standard is colonoscopy, and the three that are above the line are standardly recommended. This is expensive, and you can end up with some false reassurance if you miss studies. Here are cost effectiveness data, and they all actually fit within the standards of cost effectiveness for cost of life gain. Here you see the cost of colon screening compared to other things that we commonly do for screening, and colon screening is as effective as hypertension screening in saving lives. Last words, it's far more embarrassing to die of a preventable disease than to undergo any of these screening tests. And with that, I'll close and we'll introduce our next speaker.